Thank you, Dr. Barashi, for a nice introduction and inviting me to talk on case-based discussion unexplained thrombus PNH. Actually, it's a C5 day, so challenging C5 I use as a challenging word of PNH cure, control, or close surveillance of PNH clone. So I use acronym as CATCH, which stands for cytopenia, aplastic anemia, thrombus, Coombs negative test, and hemoglobin urea. So good evening, ladies and gentlemen. Next 15 minutes, I will take you five high five habits, C5, five habits. PNH past, present, and future production, what to remember in PNH, real world experience, then advantage of C5 inhibitor therapies, eculizumab and revelizumab. And finally, my question is, how do you catch and control the PNH? So first we will go these two things. Five questions. Question number one, what was the 10-year survival rate of PNH before 2000? Here you can say, comparing to age and gender matched control, you can see within 5 years, 35% of patients with the PNH die within the 5 years of the diagnosis. And the most important, the diagnosis, the death of the cause is 40% is thrombus. So what was the 10-year survival of PNH after 2000? It reached, you can see, up to 70% people survive. Why? Because this is impact of allogenic transplant which came there, and this was actually paradigm shift in those days. But after 2006, here you appreciate the survival increased from 70 to up to 85 to 90%. What happens? This is because of C5 inhibitor therapy impact. This is the Europe evidence which has shown survival is comparable to age and gender matched control population up to 8 years. And similarly, this is US evidence. They have shown the survival is same as normal population. Now, question 4 is PNH journey till today. As somebody has told, the longer you can look back, further you can look forward. So PNH is fatal disease. It identified 100 years ago. It was described as a poorly understood. But as somebody has told Mr. Verco, that I don't wish by any means infer the disease which is incurable. I hope, on the contrary, that so many remedies are coming to discover the treatment. So if you go by PNH, it started 1.5 century, then ham test, then sugar test, then PIGA mutation comes, then failure, and now we are here actually eculizumab. The 3 studies were done, first pilot study, and then based on the 87 and 97. So these studies were so good and paradigm shift. Here you can imagine they were published in 2004, New England Journal, and the Blood, very important publication it was done, and then they follow the long-term extension trial. So fifth question is, if all is there, what is still unmet and how that can be solved? Here you can say the survival reach almost equivalent to normal population, but still there is some problem. Where there is a will, there is a way we can use the fifth step. The reason is, as we know, PNH is actually misnomer. That causing actually delay the diagnosis, because PNH is neither paroxysmal nor nocturnal. It can happen chronic, it can happen anytime. And hemoglobin urea is only 25%. So this is misnomer. And delay the diagnosis, 40% people die because of thrombus. So these are the 2 reasons. So how can we solve the reasons? So step 1 is, as I use CATCH. So CATCH is actually acronymous. We suggest diagnosis of PNH be considered in patient presenting with otherwise unexplained cytopenia, marrow failure, unprovoked or unexplained unusual site of thrombus, Coombs negative, and hemoglobin urea. You think about the PNH, and we suggest when you're thinking about the PNH, you have to go through the proper history. Number 2 step, when and what happened, fatigue, thrombus, where is the location, and third step is proper investigation, hemolytic workup, and flow cytometry, which we call as a FLAIR, and organ function and imaging tests, we do it, then we solve the problem. So in real world practice, let's see what we do. So we have PNH, 4 type of the cases. One is classical PNH, other is PNH in setting of bone marrow failure disorder. Third is subclinical PNH. And fourth is where we use eculizumab, we call it the atypical hemolytic uremic syndrome. So I will go through these. So first case is 62-year female who was having generalized weakness last Ramzan, and she was in Egypt, very severe anemia and pneumonia, landed into ICU. Finally, she was discharged as a hemolytic anemia with the cortisone. She came here in the UAE, she was using cortisone. She came in our ER emergency Tamam hospital with a headache, vomiting, and bulge vision with a papilloedema. So here is again, 2 things are missing. Don't go misnomer PNH, and don't let the patient die with the DVT. So what is the catch? Catch is here. Rule number 1, what is when it comes to unprovoked VT, the catch is what? Nothing replaced good history and physical. So we went again, dig the history. She had progressive headache on steroid, no other comorbid. The important thing is she has persistent anemia despite abnormal the nutrients. So she underwent MRI, and the catch was there. She had thrombus, which involved the superior sagittal sinus. And the important thing is this thrombus was unprovoked, unexplained, and unusual site. So this is how done. Third step is which of the following is the most useful achieving the diagnosis of this patient? As I mentioned, second step is doing the test hemolytic workup, which was done here, DET negative. All the hemolytic workup was done, especially LDH, you can appreciate more than 1,000. Now, what would be the next step? Next step will be the flow cytometry of the PNH cell, which was we done here. And here you can appreciate it was 61%, very high clone of this patient. Now, what is the next step? Next step is important, is how to treat. Do you treat with the low molecular weight heparin only, or dual therapy, low molecular heparin with the eculizumab, or triple therapy with steroid as well? So first thing is, first we notice what is the indication of eculizumab in this patient. And here you can say the important thing is thrombus, which is related to PNH, which is the important indication of eculizumab. So in this case, we use dual therapy with low molecular heparin and eculizumab. And here you can see 6-month journey of this patient. First week, the decreased hemolysis as measured by LDH, which is going down, and decreased headache and fatigue, and better quality of life second week. And from second week to 6 months, no need of transfusion, and LDH is normalized. And this is the protocol which we use, induction phase, 600 for 1 month, and then 900 every 2 weekly, and this will continuously. So this is the whole journey which we use, catch and control till journey. I use all the 3 steps. Case 2, 21-year female who was referred in Tamam 2015 actually. She had history of anemia, a recurrent admission for the blood transfusion, recurrent abscess. Why was she sent finally? Because she developed pancytopenia. Now the thing is, again, when it comes to unclear pancytopenia, what is the catch? Catch is, please do again history and physical. So we found in this patient, she has persistent anemia despite of normal nutrients. So here is the catch, unknown cytopenia. So what is the step? We did hemolytic workup, again, DET negative, all hemolytic workup. Here you can find LDH up to 900. And important thing, this time she landed it with high creatinine, low GFR. So this is how we did another test. This is flow cytometry, which is 66% clone of the PNH. Here you can say first case was diagnosed here, and they informed pathologists that in those days actually PNH. So what is the next step? As there was pancytopenia, so we have to do marrow. The marrow is essentially normal, nothing in the marrow. So what is the including criteria of eculizumab in this patient, severe cytopenia. An important thing is renal dysfunction. So there are two indications there to give eculizumab. So what is the treatment? Treatment is steroid and eculizumab, which was given in this patient. This is the 12 years journey of this patient so far. Now she's following, and here you can see kidney become normalized, hemoglobin, no need of transfusion except one time, and LDH is normalized. This is 12-year journey, and this is the protocol which I mentioned before, weekly for 600 and then 2 weekly 900. This was given. So what we learn in case 1 and 2, case 2 is do hemolytic workup, and for differential do flow cytometry. Rule number 3 is never forget rule number 1, which is nothing replace good history and physical, which I did in both patients. Now, very simple case 3, actually this is young male who has cytopenia, PNH clone was 82%. The important thing is the very poor compliance. He used to last to follow up, and this leads to us very difficult to continuous transfusion, and we did so many bone marrows. So in this case, actually we are thinking, we wish we can give a long acting like eculizumab, which is coming now, will start in this patient. Now, case 4 is actually 38-year young male. Again, he was diagnosed with the cytopenia. Again, we catch it, and we did PNH clone that was 42%. And this you can see the very good journey of this patient from 2013 till 2021. He hardly need any blood transfusion, and he's doing very well with eculizumab. Now we will go to second type of patient we call the hemolytic uremic syndrome. This young lady actually diagnosed hemolytic uremic syndrome and advanced kidney disease, hypertension, hypothyroidism. This case was thoroughly seen all over the world. She went to UK. Here you can see she went to US, she went to Germany. In 3 different countries they have gone through 1.5 years, and finally everybody concluded it's better because she was not responding. She was deteriorating, continuous blood transfusion, creatinine was going up, eculizumab was decided, and here you can see over the 9 years she's on eculizumab, and she was given the creatinine is now normalized and LDH is normalized and no more blood transfusion. So this is third case, PNH in setting up marrow disorder. The marrow disorder, like this is 43-year lady who had actually psoriatic arthropathy, and she was on methotrexate, and she developed cytopenia. The question is what we should do. First thing, bone marrow was done that revealed that was compatible with the aplastic anemia. When aplastic anemia, you have to do flow cytometry. That was done, and you can see the clone was only 1.50. So it was very low clone, which was seen in this disorder. So that, as everybody know, the bone marrow failure syndrome can happen to these things, and the treatment options is either you treat PNH or you treat the bone marrow failure. We treated in this patient bone marrow failure as PNH clone was very low. Now, here, there is close surveillance of PNH. We don't use the eculizumab in this patient. Now, another patient, subclinical PNH diagnosed, subclinical, like he had cytopenia, but you can see the flow cytometry, which were revealed in 2015, it was 9% clone, and even in 2021, the clone is about 4%. So this patient is also close surveillance of PNH clone, no need of treatment. So you have seen I presented classical PNH. PNH is setting up bone marrow failure, and PNH, subclinical PNH, and atypical hemolytic uremic syndrome. Now, this is my bonus question. What to consider PNH? Do you agree with me to consider catch? C5 agenda is what? Challenging word of PNH, catch and control, or close surveillance of PNH clone. So what do you think? Did I went through the high five like this one? Yes, I following according to principle, not following the opposite way. So last 15 minutes, I have gone through the unexplained thrombus with the case, past, present, and future of PNH, what to remember, catch and control, real world cases, and the importance of the C1-5 inhibitor like C5 agenda, challenging word of PNH, catch and control, and close surveillance. And the last slide is here. In teaching, the greatest sin is to be boring. Hopefully, I didn't bore. He who learns, who will teach. Thank you very much. If any question, please write down on the board. I am here with you. Thank you, Dr. Marashi.